Medical news from JAMA Cardiology. What breast cancer treatment may mean for your heart. Patients undergoing therapy for breast cancer face a hidden threat. The heart can be collateral damage from the very drugs that eradicate malignant cells. Recent syntheses of clinical data reveal that anthracycline chemotherapy, HER2-directed agents such as trastuzumab, and thoracic radiation each carry a measurable risk of cardiac dysfunction, ranging from subclinical declines in left ventricular ejection fraction, LVEF, to overt heart failure, and these risks are amplified by pre-existing cardiovascular risk factors. Recognizing and mitigating these hazards is essential to preserving long-term survival, especially as breast cancer cure rates continue to improve. Breast cancer remains the most common malignancy among women worldwide, accounting for roughly 2.3 million new cases annually and responsible for over 600,000 deaths each year. While advances in systemic therapy and radiotherapy have dramatically lowered mortality, the cardiotoxic sequelae of these treatments have emerged as a leading cause of non-cancer morbidity. Historically, the link between anthracyclines and irreversible cardiomyopathy was noted decades ago, yet the introduction of HER2-targeted monoclonal antibodies and modern radiation techniques has created new, sometimes synergistic, pathways to cardiac injury. The need to delineate the magnitude of these risks, identify vulnerable subpopulations, and define evidence-based surveillance strategies prompted a comprehensive review of existing trial data and observational cohorts, now distilled into a patient-focused JAMA Cardiology page aimed at clinicians. The underlying evidence base comprises prospective randomized trials of adjuvant anthracycline-based regimens, large Phase 3 studies of trastuzumab, including the pivotal HERA and SAB-B31 trials, and registry analyses of women receiving left-sided chest irradiation. Across these investigations, cumulative doxorubicin doses exceeding 300 mg per square meter were associated with a 510% incidence of symptomatic heart failure within 5 years, and a 1520% prevalence of asymptomatic LVEF reductions greater than or equal to 10% from baseline. In the trastuzumab arm of the SAB-B31 trial, 2.5% of patients developed clinical heart failure compared with 0.4% in the control group, hazard ratio 2.9, 95% CI 1.94.4, p less than 0.001, while up to 19% experienced a greater than or equal to 10% drop in LVEF without overt symptoms. Radiation therapy to the left hemithorax conferred a relative risk of coronary artery disease of 1.52.0 in the first decade post-treatment, rising to 47% after 20 years, particularly in women older than 60 years at exposure. Importantly, pooled analyses demonstrate that concurrent administration of anthracyclines and trastuzumab escalates the odds of cardiotoxicity threefold compared with either modality alone, underscoring a dose-dependent, synergistic effect. Subgroup examinations consistently highlight age greater than or equal to 65 years, baseline hypertension, diabetes mellitus, and a pretreatment LVEF below 55% as independent predictors of adverse cardiac outcomes. Women with prior exposure to chest radiation or those receiving high-dose anthracyclines, greater than 400 mg per square meter, exhibit markedly higher event rates, and genetic polymorphisms in drug-metabolizing enzymes, e.g., NADPH oxidase variants, have been implicated in heightened susceptibility, though these findings remain exploratory. Early-stage reductions in global longitudinal strain on speckle-tracking echocardiography have emerged as a sensitive marker, often preceding overt LVEF decline by several months. The clinical. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.